Hello and welcome to today's webinar. My name is Ruth Richardson and I'm the Director of Programs for the Minnesota Organization on Fetal Alcohol Syndrome, and I will also be the moderator for today's webinar on the FASD basics. We are very happy to have you join us today for the presentation by Dr. Jeffrey Wozniak. All attendees have been placed in listen-only mode for the duration of the webinar. If you experience any technical difficulties or if you have any questions, please use the questions box or the chat box and send those directly to the organizer, and I'd be happy to assist you with any technical issues. I'll also track any questions received for our presenter, and at the end of the presentation today, we will have a Q&A session. Continuing education units are available for this live webinar. We've been approved by NADAC to provide CE for addiction professionals. We've also been approved by Professional Education PAL to provide CE for educators. We've been approved by the American Psychological Association to sponsor continuing education for psychologists, and also by the National Association of Social Workers to provide continuing ed for social workers. This course has also been accredited to provide continuing medical education for physicians through the Accreditation Council for Continuing Medical Education. And finally, we have also been approved to provide continuing education for nurses through the American Nurses Credentialing Center. In order to receive CEUs, attendees will be required to attend the entire live webinar session and to complete an evaluation following the presentation. Some attendees may need to also do a post-test. Individuals that are seeking addictions, social work, or educator credits will complete an evaluation that will appear immediately following the webinar. These certificates of attendance for addictions, social work, and educators will be sent within 7 business days. For individuals seeking physician, nursing, or psychologist credits, you will be provided a code during the live webinar to access those evaluations. When the code is read, please make a note of that for your records, and following the webinar, you'll receive more information on how to access your certificate. Please note, for all disciplines, the deadline to request continuing education is November 29th, 2014. Finally, we need to let you know that this webinar is not supported by any commercial interest, and the presenter has no financial relationships to disclose. Today's session will be presented by Dr. Jeffrey Wozniak. Dr. Wozniak is a nationally recognized speaker, an associate professor in the Department of Psychiatry at the University of Minnesota, and is also co-director of the university's FASD program. The floor is now yours, Dr. Wozniak.
Thank you, Ruth, and thank you for the introduction. As Ruth mentioned, I work at the University of Minnesota, and my background is in pediatric neuropsychology, and I'm a clinical psychologist. And I do a combination of practice with general peds neuropsychology and a fair amount of research. And as she mentioned, I'm the co-director of the FASD program, and I oversee the research programs here, some of which I will talk about during today's talk. But for the most part, today's talk is going to be the basics. So we're going to cover a variety of issues related to sort of general introduction to what FASD is, what we know about it, and a little bit about brain imaging, a little bit about prevention. We're going to cover kind of a range of topics. So let's go ahead and advance here. All right. So the objectives for today's webinar are to first understand the terminology that we're talking about with fetal alcohol spectrum disorders. This is confusing terminology, and it's changed many times over the years, so we're going to go through that in a little bit of detail just to kind of bring you up to speed to the current terminology. We will talk about the underlying brain basis of FASD. This is a neurodevelopmental disorder, and I'll give you some evidence for that, and then I'll also talk a lot about what we think that results in terms of neurocognitive and behavioral abnormalities that go along with FASD. So before we really get into the heart of the presentation, I thought I would just throw a little quiz out there and ask this question. Who among these three individuals that you see here listed do you think is at highest risk for having a baby with damage from alcohol exposure? So which one of these women is likely to have a child with fetal alcohol spectrum disorders? Is it a 28-year-old unemployed Native American woman who's living on a reservation, a 17-year-old straight-A student from a small Midwestern town who does not have a boyfriend, or a 34-year-old marketing executive from a wealthy suburb who is newly married? Now, based on your understanding of FASD, you might think that the first woman is at risk for having a baby with FASD. This is kind of the stereotype, and it's an unfortunate stereotype. And hopefully, by the end of this first slide, we can kind of dispel some of these myths. So let's take that first woman, and she is someone who suffers with chronic alcoholism. She drinks hard liquor. She has, in addition, poor access to prenatal care, which puts her at higher risk for having a child with a neurodevelopmental disability. And she may, in fact, expose her fetus throughout the pregnancy. And so this is a very high-risk situation. And obviously, this is a person we want to target with prevention efforts, treatment efforts, etc. But what about this young woman, this teenager from a small town who doesn't have a boyfriend and is a straight-A student? This would seem like a low-risk individual. But in fact, this individual is having casual sex, and she's not using birth control. This is not a surprising situation for a 17-year-old. And in fact, she's unaware that she is pregnant for at least the first month, let's say even into the second month. She's not that familiar with her cycle. She's not that familiar with the signs of pregnancy. So she continues to go about her normal behavior, which includes drinking on the weekends and partying. And this is not an uncommon scenario, especially here in the Midwest. Rates of binge drinking among women of childbearing age are very high. Okay, what about this 34-year-old marketing executive, someone who probably is educated and knows the dangers of prenatal alcohol exposure? She has adequate resources to have good prenatal care, and she's newly married. So it turns out that she's also unaware that she's pregnant for the first month. She's a wine drinker. It's a socially appropriate thing to do. She doesn't drink excessively, except occasionally at a gathering with friends or a bachelorette party or a happy hour, those sorts of things. She's also putting her fetus at very high risk with those particular drinking behaviors, even during this first month of pregnancy. Even more concerning is that when she learns that she's pregnant, her obstetrician tells her that it's basically okay to continue to drink wine as long as it is not excessive, and in fact, it might help her relax. So she gets the okay from her obstetrician. This is not an uncommon scenario. In fact, this happens all of the time, even though the major organizations, World Health Organization and the Surgeon General and the CDC and everyone else suggests that alcohol should not be consumed at all during pregnancy. So what we know is that alcohol is capable of damaging a fetus at any point in development, even including these very early stages when most women are simply not aware that they're pregnant. And the research shows that even a single binge episode can cause very significant brain damage. And I'll show you some animal studies that we have in a little bit here to basically point that out a little bit more. So for some perspective, let's think about what stage of development we're talking about here. And we oftentimes see the prevention literature and prevention materials around fetal alcohol all have pictures of large-bellied pregnant women. It's the obvious symbol of pregnancy, and this is what's in people's minds. When you have a large belly and you're fully pregnant, to use a euphemism, that's when you should not drink. But in reality, what we're talking about with some aspects, many aspects of fetal alcohol spectrum disorder, goes back to very early in the pregnancy. So here's day 17, this first panel on the left here, and this is what a human being looks like at day 17. Hopefully you can see my mouse cursor pointing to this first upper left panel on this page. And this is basically a collection of cells at this point, and I'm showing you the equivalent in mice here because we're gonna look at an animal study to show you how we understand this about fetal alcohol spectrum disorders. But this is day 17 in the human pregnancy, a time when, of course, most women simply don't know that they're pregnant. So now I want you to think about this penny here, and look at the 0. If you have a penny in your pocket, or when you go home tonight, grab a penny, and look at the 0. And that is that a fetus at day 17 would actually fit inside the 0 on that penny. So that gives a little perspective to the question of how much damage could a little bit of alcohol do to a fetus. Well, we're not talking about a fully grown fetus with a liver and the capacity to handle alcohol here. We're talking about a collection of cells that would fit inside the 0 on that penny. Okay, so we know a fair amount about this risk from animal studies, and some of these studies go back to the 1980s. This is one particularly influential set of studies done by a researcher named Kathy Sulik at the University of North Carolina, and she developed a model in which mice were given, pregnant mice were given alcohol on day 7 of the pregnancy, and again that's equivalent to about day 17 or 18 in the human. And what you see when you do this, if you give the mother doses of alcohol on day 7, is you create a pattern that looks a lot like fetal alcohol syndrome. So here in panel A on this screen, you see a child with fetal alcohol syndrome, and there are some characteristic facial features. This child has small eyes and a flattened midface. The groove above the upper lip is missing, and it's flattened. The upper lip itself is thinned, and you can see these same facial characteristics in these mice that are exposed to alcohol on day 7. So the first mouse here, panel B, is a mouse with essentially fetal alcohol syndrome. This mouse has small eyes. This mouse has an abnormal philtrum. You see the groove above the upper lip is much different than the normal mouse over here, which is labeled C. And the head is in fact smaller in this B mouse, and the brain is also smaller in this B mouse. So this alcohol exposure produces a pattern of brain abnormalities that we call holoprosencephaly, and these are very gross abnormalities in brain development. So there are structures missing in the brain. The forebrain can be malformed. The midline can be very malformed. There are corpus callosum abnormalities. The hippocampus is very affected. Multiple structures are damaged heavily by alcohol during this stage of pregnancy. Interestingly, when she gives alcohol on day 8 to 8.5 in these mice, which is the equivalent of about day 21 to 24 in humans, she doesn't get this pattern. And this has been demonstrated many times now. And what this tells us is, number one, that there's a period of very early on in pregnancy where the fetus is extremely vulnerable to alcohol, not only the face but the brain. The other part that is interesting about this research is that the window of time when the face is damaged is very narrow. In fact, it's only about a day in the mouse, and it's probably a couple of days in the human. So the way that we make this diagnosis, which we'll get to a little bit later, actually depends on the facial features being there, because this is how we identify that a child has been exposed and damaged by alcohol. And what that tells you is that there are many, many opportunities during the pregnancy for the child to be exposed to alcohol without damaging the face. If for some reason that window of time when the face is undergoing this crucial formation period, that if there's some reason that why there was no alcohol on those days, the child won't have these facial characteristics. but it may very well have the brain abnormalities as a result of alcohol exposure. So the FACE is a very imperfect clinical diagnostic component. So despite all of this that we know from nearly 40 years, fetal alcohol spectrum disorders and fetal alcohol syndrome were really identified back in the 1970s. So we have 40 years of evidence that very clearly indicate the risks and the damage that is caused. The public perception still remains very inaccurate, and I just want to take a few minutes to kind of talk a little bit about this. If you pay attention to popular media, you will see repeatedly stories about alcohol use and various people with various backgrounds coming out and arguing with the public health perspective that alcohol is dangerous during pregnancy. So here you have some examples. This is in 2013. There was a book that came out called Expecting Better, and this book basically tried to give women permission to drink alcohol during pregnancy. So this was written by Emily Oster, an economist who basically has expertise in crunching numbers. And she read a bunch of the studies and wrote this book basically suggesting that the studies didn't indicate any damage from low levels of alcohol exposure. So she made a huge splash, was all over the news. And as you can see here, she's got 60,000 plus followers on Facebook. I'm not sure how many copies of the book have sold, but a very kind of dangerous proposition and very attractive to the media because it grabs people's attention because it's controversial. Here's another example. This CNN still is from a series of studies that came out in Europe, which actually looked to try to find evidence of cognitive abnormality, developmental abnormalities in kids who were exposed to low to moderate levels of alcohol, and they did not find that. And so those stories made that research made the news, again in kind of an unfortunate way. Basically, you have people on TV saying this is evidence that there's a safe level of drinking during pregnancy. In fact, in science, that's not the case. If you do a scientific experiment and you don't find a result, that doesn't prove anything. You just haven't proven your hypothesis, but you haven't disproved anything. You have not proven safety. So here's another one just from last week. Unfortunately, this came out in Cosmopolitan magazine, and you can see the title, Why I Drank While I Was Pregnant. And so this, within a matter of a week or so, has already generated thousands and thousands of shares on Facebook and lots of comments. I didn't show you the comments here, but there are hundreds of comments already to this particular posting. So this is out there. The reality, of course, is that fetal alcohol spectrum disorders are very serious, and at the public health level, this is an enormous problem. And here's some of the numbers. So in the United States, we know that a fair number of women drink some alcohol during their pregnancy, something like 13% knowingly drink while pregnant. About 1% drink heavily while pregnant, even though they know that this is not safe. And something like 3 to 4% binge drink. So these women may not consider themselves heavy drinkers, but in fact, based on the research, we know that binge drinking can cause this damage. The real problem is that nearly half of pregnancies are unplanned, and so women are not of the mindset when they're doing this drinking to think that they might be pregnant. So the latest estimates tell us that fetal alcohol syndrome is about 2 per 1,000 live births. That's the incidence. And that for the larger spectrum, all kids affected by alcohol exposure, it's somewhere in the range of 2 to 5%. There are some new numbers that just came out this month in a pediatrics article, and the first set of data that these epidemiologists have looked at is coming from a nearby state, and that data is showing even higher rates, up to 6 to 7% for the whole fetal alcohol spectrum disorder spectrum. Sometimes I get asked this question about, well, I don't really believe this because in Europe they drink, it's routine for people to drink during pregnancy and they don't have problems with fetal alcohol spectrum disorders. And that just isn't true. The studies have been done now, and we know that, for example, here is a case in Italy where the rates of fetal alcohol are 2 to 6%. So very much equivalent to what we're seeing in the United States. In some cases, even higher. There are regional variations around the world, but very similarly developed European countries, high socioeconomic status, high levels of education, you still have these high rates of FASD. So let's talk about what a binge is so we know we're all on the same page. With a typical woman of typical size, 4 or more standard drinks in 2 hours is considered a binge. And we know that many women engage in binge drinking. Many men do as well. This is a very common pattern in our culture. Something like 15% of women who are childbearing age binge drink. The high risk is in these 18 to 24-year-olds. They have the highest binge drinking rates, but look at this here. Ages 35 to 44 are actually the most likely to continue drinking even after they learn they're pregnant. So at the 18 to 24-year-old level, you probably have young women who are not as aware and maybe less aware of their pregnancies. At the older age levels, you have women who feel maybe more comfortable with their drinking patterns, maybe more comfortable not following the traditional advice, and they're likely to continue drinking, including those women who are college educated. That's associated with, in fact, continuing to drink during pregnancy. And we now know that, of course, that the peak level of alcohol exposure is a risk. So we're not talking about a syndrome or a spectrum of syndromes that requires that a woman drinks throughout pregnancy. We know that what's really critical is reaching a high peak level of alcohol, which can happen with a binge. So here's one of those animal studies I was referring to earlier. These are rodents, these are mice, and this is looking at a process called apoptosis. So in the developing nervous system, we have this mechanism that's built in to basically cause cells to self-destruct. And that's important in normal brain development. The brain creates way more cells than it needs, and eventually it cuts some of those away. That's a normal developmental process. Alcohol has the capacity, because of its chemical structure, to signal this process to take place. It tricks the system into self-destroying these neurons, or these brain cells. So this is an example. The figure on the left shows you a normal brain, and the figure on the right has been stained. The brain has been stained to show you cells that have died by apoptosis. And you can see the widespread damage from alcohol that causes these cells to basically self-destruct. And this is a single binge model, so this was a single episode of alcohol exposure, high alcohol exposure, but nonetheless a single alcohol exposure. So when we talk about humans, of course, we're wanting to ask the question, well, how much alcohol are we talking about? What are the patterns of drinking like? What's risky? What's not risky? Here's a few things to think about. A standard drink is basically what you see here: 1 beer, 5 ounces of wine, 1.5 ounces of hard liquor. In fact, people don't belly up to the bar and ask for one standard drink. And so there is a huge variation in how much alcohol is in a, quote, drink. And the estimates are that most women tend to overpour and underestimate the size of drinks, especially when they're talking about hard liquor. So something like 30% of women of childbearing age are basically classified as risky drinkers because of this combination of binge drinking and not necessarily even knowing what a binge is and what a standard drink is. So here's some more examples. Oftentimes in mixed drinks, the amount of alcohol is between 2 to 5 times more than a standard drink. So depending on what the person's drinking, one of these drinks can easily get a woman even close to the binge level. 2 drinks certainly could do it. And here's an example with wine. Sorry, my telephone's ringing in the background. That will go away in a second. Here's an example with wine, and a glass of wine with a healthy pour can be 2 to 3 times more alcohol than a standard drink. So you can see how it's very easy for women to reach a peak level of alcohol, a binge level of alcohol, without drinking in a way that seems excessive. So here's the unfortunate confluence that we have. We have this culture of drinking that we all live in. We have the fact that brain damage can occur very, very early on in pregnancy, the timing aspect. We have unprotected sex and lack of planning for pregnancy. And then we have this pregnancy unawareness condition where most women simply don't know that they're pregnant until some of these very high-risk periods have already passed. And this confluence leads to, unfortunately, to high rates of fetal brain damage. So let's talk about some of the terminology next. Fetal alcohol syndrome is the name that was given to the most extreme form of this condition that we're going to talk about. And this term was first used back in 1973, and it was used, and the syndrome was described by Dr. David Smith, a geneticist, and Ken Lyons-Jones, who is a pediatrician and also a dysmorphologist who studies birth defects. And this was discovered at the University of Washington. They identified a series of babies that had small growth and facial abnormalities, and they discovered that their mothers had in common alcoholism. So we now diagnose this condition based on facial dysmorphology. I talked a little bit about the eyes and the lip and the mid-face. There are a number of facial characteristics that go along with being exposed to prenatally to alcohol. And so we have ways of measuring those things and formally characterizing those things. There are normative data that tell us how big the eyes should be, how long the philtrum should be above the upper lip, etc. So we can characterize individuals based on those things. Growth is also important in fetal alcohol syndrome. In the full syndrome, these are individuals who are small in terms of height and weight. And that's a characteristic that continues pretty much throughout life for those with full fetal alcohol syndrome. They remain growth impaired. Brain anomalies are another part of this, and these can be identified in a couple different ways. Sometimes these are individuals who have obvious gross structural abnormalities when you look on something like an MRI scan. And at other times we're identifying the brain problems based on cognitive testing. So we are testing in children, for example, memory, attention span, intellectual functioning, and we're finding these abnormalities. That's part of the diagnostic criteria. And the fourth part of the criteria has to do with alcohol exposure. So in order to get a diagnosis of FAS or FASD, we have to know something about alcohol exposure. And this varies. Sometimes we know very clearly that the child was exposed. We have first-hand information. Other times we have suspicions based on second-hand information. And so the diagnosis allows for different levels of alcohol exposure in combination with these other things. The terminology is just plain terrible, and it has gone through a number of changes over the years. So we used to talk about FAS, and then for a while we talked about fetal alcohol effects, FAE, which were kids who didn't have the full syndrome but had some effects. There's the term partial fetal alcohol syndrome. Again, these are kids who have maybe some of the characteristics but not others. And there's alcohol-related neurodevelopmental disorder. This is a situation where you have even less of the criteria that are met, but you still have an indication that there's been brain damage from alcohol, and a number of other diagnostic terms here. The term PAE, or prenatal exposure to alcohol, simply refers to the fact that a child was exposed. And this is coming back into use now because of DSM-5. So for those of you who don't know, DSM is the manual of all of the psychiatric disorders. And so psychologists and psychiatrists use this manual to make diagnoses. The diagnosis in DSM-5 that fits best with fetal alcohol spectrum disorders is something called neurodevelopmental disorder, PAE, or prenatal exposure to alcohol. So we're now at the point where we are identifying, at least from DSM, kids who have neurodevelopmental disorder and who we know were exposed to alcohol prenatally. And so to some extent, psychiatrists and psychologists are using that term already, so you will see that in common use. FASD, or the spectrum, is really it's really an umbrella term. It covers everything that relates to kids and adults who have exposure and have some level of damage from that exposure. And so FASD includes a wide range of things, including physical anomalies, like we talked about, intellectual impairments, behavioral problems, learning disabilities, any number of cognitive impairments. FASD is not a clinical diagnosis. It's just a term that we use to kind of describe the whole group of individuals who are affected by prenatal alcohol exposure. The most commonly used terms these days that are diagnostic terms are these three: fetal alcohol syndrome, and this is the full-blown syndrome where the individual meets all of the criteria. Interestingly, in this case, you don't necessarily need to know whether there was alcohol exposure to make this diagnosis, because if a child is growth deficient, has three of the facial features that we talked about, and has some level of brain impairment, they have fetal alcohol syndrome, regardless of whether or not you clearly know about their alcohol exposure. Partial SAS, you may know about the alcohol exposure or may not. You have to have two facial features, have to have some evidence of brain impairment, and you may or may not have the growth deficiency. ARND, alcohol-related neurodevelopmental disorder, here you have to know that there was alcohol exposure. You have to have some indication of brain impairment, and usually this is based on cognitive testing. You may or may not have facial features, and you may or may not have growth deficiency. ARND, as you might be guessing, is somewhat of a muddy diagnosis. It's somewhat controversial because of that. Some people question the validity of this diagnosis, and we have yet to really have a precise definition that everyone agrees on for ARND. I don't know that we ever will have a diagnosis that everyone agrees on, but you will see this term used, and this is a large number of individuals fall into this category of ARND. So here are some of the cognitive consequences of prenatal alcohol exposure. We know that these individuals have sometimes full-blown intellectual impairments. They may have IQs that are in the impaired range, like below 70, but not always. And in fact, most of the time, their IQs are somewhat higher than that, in the 80s. These individuals can have sensory problems. They definitely can have problems with mood regulation and behavior. They have difficulties with attention and things like working memory, which is basically concentration. And they definitely have impairments in their ability to exercise good judgment, their ability to reason through problems. Their executive functioning skills are impaired, so they don't plan well, they don't organize well, they don't respond to consequences well. And their social functioning, adaptive functioning, is impaired. So these are individuals who oftentimes need lots of extra help with day-to-day living. And so if you're talking about a child, you're talking about someone who's going to need a lot of extra structure just to be able to do normal developmental tasks. And if you're talking about adults, talking about someone who's going to need help with independent living. Typically, to make a diagnosis, we think about 3 domains of cognitive functioning. So you can't just have an impairment in one of these areas and some alcohol exposure, and we call that FASD. You really need to have at least 3 areas of impairment. So here's a typical battery, just to give you an idea. If there are any psychologists among the audience, you'll recognize that this is kind of covering the spectrum of cognitive functioning. So we look at intelligence, we look at those independent living skills, we look at different aspects of attention, how well can the individual pay attention for long periods, how well can they shift their attention, and some of these executive functioning things I mentioned, language functioning, especially what we call pragmatic language, or the ability to actually use language to get things done. Sometimes an individual's language skills will be normal. They have normal vocabulary and their speech is normal, but they can't use language effectively to explain an idea, to get a need met, or to comprehend what another person is saying to them at an effective level. And then there are other areas where we evaluate things like motor skills, visual perceptual skills, and behavioral functioning. Many of these individuals with FASD have problems like hyperactivity, emotion regulation, and mood regulation. Unfortunately, FASD is a precursor, or it sets people up to develop psychopathology. And the rates are extraordinarily high. So these studies go back to the 1990s and early 2000s, following individuals who have fetal alcohol syndrome. And you see the very, very high rates of substance abuse, major depressive disorder, bipolar disorder. ADHD is almost universal in these individuals who have prenatal alcohol exposure, learning disabilities, etc. Sleep disorders are also very high. Nearly all individuals with fetal alcohol syndrome have some difficulties fitting into the kind of normal expectations of society. Okay, let's shift gears just a little bit and talk about screening and diagnosis. Some of you may be working in settings where you're involved with screening or potentially could be involved with screening. What are the different settings where we do this kind of work? First off, the most obvious place is within the OBGYN setting, where you have pregnant women who are having contact with medical professionals. This can include not yet pregnant patients, so there are opportunities in OBGYN settings for physicians and nurses and other healthcare workers to convey these messages to women who might become pregnant. But what about some of these maybe less traditional places to think about prevention and education? There have been efforts to get family practitioners who are seeing many women of childbearing age, of course, for various things, to ask these questions about alcohol use as a routine and to give this message of no safe alcohol use during pregnancy. If you think about pediatricians, this is another opportunity. Pediatricians are seeing women who have children and who may very well be having other children, and whose social groups include women who are having children. So this is an opportunity to give this information. And certainly there are some high-risk populations or sub-pockets of the population where we do treatment and prevention work, and that includes women who are undergoing substance abuse treatment. These are high-risk women for having kids with FASD. What we've learned, and MOFAS has done some pretty extraordinary work here in the state of Minnesota to get this screening into clinics, and we've learned a lot about what works and what's important. It's critical to make this an automatic process. Number one, healthcare professionals are still not comfortable asking these questions about alcohol exposure during pregnancy. So putting this information into the standardized intake materials and into the electronic medical record makes it automated and makes it easier to get this information. And it becomes just part of the data collection so that it isn't, a woman doesn't feel necessarily stigmatized when she's being asked these questions. They're part of the standard set of questions. It's important to train staff nonetheless on how to do this because it isn't the most comfortable topic to approach with women, especially women who are pregnant. It's very important to have a plan of action. So if screening is taking place in a clinical setting, there really does need to be kind of a flow chart for what happens when women acknowledge alcohol use during pregnancy. Where do they get referred? What kind of treatment do they need? What are the ramifications? And so clinics generally need to develop this flow chart and a resource directory for where to make these referrals. Some other creative ways that clinics can give this information, for example, when giving pregnancy test results, is another point of contact that can be, at which this message can be delivered. So what we know is that it's very important to ask about alcohol use during pregnancy, but it's useful to establish that to start before that. So asking about the drinking pattern before a woman knew that she was pregnant is really critical. Why? Because this predicts the drinking during pregnancy. And it also acts as a lead-in. So it's easier for women to say, yes, I may have had some alcohol when I didn't know I was pregnant, if you lead into with these questions about what the drinking pattern was like prior to that. And it's also very critical if you have women who are at high risk, so women with chemical dependency. We know that the questions can't be simple yes/no questions. You can't just say, are you drinking? Yes, no, okay, let's move on. It needs to be a little bit more of a conversation, and so again, starting with what was your drinking pattern like for the last year or so. Have you ever had any substance use problems in the past? When you drink, how often do you drink? What kind of things do you drink? When was your last drink? And how did that pattern change once you learned you were pregnant? It's oftentimes very revealing to ask the questions in that way, instead of just in a routine check the box kind of way. We've also learned that it's very important to ask about alcohol use each and every time. And this may seem redundant, but the fact is that patterns change, and a low-risk woman who is in a different situation may very well turn into a high-risk situation. So let's say a woman is in a relationship and is not drinking, and then something happens to that relationship, and something happens to her housing situation as a result of that, and suddenly she's in a high-stress situation. The next time you see her in the clinic, she may very well be at higher risk for drinking at that point. So the goal of all of these screening efforts is really not to make this into a guilt issue or to shame women for drinking during pregnancy. The goal is really to provide clear information, medical information, risk information. And really, regardless of the answers to these questions, it's important to continue to deliver this message, this public health message. Even if the woman's answer is no, I'm not drinking during pregnancy, still give the message. We know that this takes time, so that women who are seeing, let's say, an OBGYN maybe don't answer these questions totally openly the first time that they're asked, but as they build trust, they may be more comfortable answering these questions and then getting the help that they need. So each time is an opportunity to ask the questions, but it's also an opportunity to give the message that there's no safe level of alcohol exposure during pregnancy. Here's an example of what the questions can look like in an electronic medical record. Here you see before you knew you were pregnant, blah, blah, blah. Since you knew you were pregnant, again, the questions come in. And it asks about alcohol and drugs, other drugs. This is kind of an awful URL here at the bottom of the screen, but we can give this to you if you want to search this out on YouTube. You have to have this URL to find this, but there are some video examples that MoFast has prepared of how to ask these questions. And so there's several different role play scenarios in which the provider goes through and asks a pregnant woman these questions about alcohol use. If you want to see examples, and these can be used for training purposes as well. So how do we diagnose FASD? It really requires a multidisciplinary team of professionals, and oftentimes this involves a physician who handles the medical aspects. Sometimes this includes a dysmorphologist, someone who has expertise in that area. It oftentimes should involve a psychologist or a neuropsychologist to evaluate the cognitive functioning, sometimes speech and language, sometimes occupational therapy, and a social worker. Really key for the diagnosis teams is to have a person who is really familiar with the resources in that area and can sort of coordinate the team. So here's a little bit more detail on how we diagnose. I'm not going to teach you how to diagnose. It's a fairly lengthy process to learn all of the intricacies of this, but this is just an overview showing you that there are standardized ways of rating the philtrum and the lip. Over here on the left, you see different gradations of normal to abnormal philtrum. This 5 here is a very abnormal philtrum and upper lip. Here's a child with several different facial characteristics of FAS. You see that we measure the eyes using a very high-tech device here, a 49-cent clear plastic ruler. And these are the most important facial features: the eye width, or palpebral fissures, the upper lip, and the philtrum. Those are the 3 that really together kind of characterize this disorder. As I said, there are some other abnormalities that go along with FAS. Here are some of those. And these are not necessarily the definitive ones, but you will see these abnormalities. There are other dysmorphic features. For example, some of these children have abnormalities in the ear and or abnormalities in the creases on the hands. These are less common, but we do see these fairly routinely in kids who have FASD. So why do we want to diagnose this in the first place? Oftentimes people ask that question and say, well, there's nothing you can do about it, so why is it important to diagnose? It is important because we want to eliminate or lessen the secondary disability. So we know that these individuals are going to have problems at school. We know that they're going to have mental health issues. We know that they're going to be at high risk for substance abuse. And so diagnosing this and putting people on track to receive treatment for those things and prevention is critical. It's also important to really help individuals with FASD and those who work with them to understand that there are patterns of strengths and weaknesses, that these are not individuals with global impairments oftentimes. Many times they have strengths and weaknesses that can be characterized by a good diagnostic workup. And we really want to prevent future births of children with an FASD. So diagnosing children, making this condition known to parents and known to society is really critical to prevention. We've talked a little bit about how alcohol does its damage. Here are just some of the systems in the developing organism that can be affected by alcohol and are affected by alcohol. And alcohol is really unique in terms of its capacity to cause damage. Here's a quote from the Institute of Medicine back in the 90s. Of all the substances of abuse, alcohol produces by far the most serious neurobehavioral effects in the fetus. I run into skepticism about this all the time, and people are just incapable of believing that that alcohol is more damaging to the fetus than cocaine and methamphetamine and heroin. But the fact is that alcohol is more damaging. It is a teratogen. It does cause these birth defects directly, and it's because of the chemical structure of alcohol. It has nothing to do with the legality of the substance. It has everything to do with the fact that alcohol has this capacity to cause all of these biological effects including the one that I showed you earlier, that apoptosis of brain cells. So here you see just sort of graphically that alcohol causes all of these abnormalities: facial, physical, motor deficits, developmental and cognitive problems, and growth deficiency. These other drugs are certainly not good for development, but they generally don't compare to alcohol's ability to cause this damage. We know that alcohol is really the sole cause of FASD, right? So that this is really a 100% preventable condition if you don't drink during pregnancy. But there are a number of other factors that figure into this very considerably, actually. So one of those is maternal age. We know that advanced maternal age causes higher risk situation and increases the risk for FASD. General health and nutrition also increases the likelihood of FASD. So if a woman is deficient in certain nutrients, for example, she's putting the fetus at higher risk if she's also consuming alcohol. Interestingly, there are also genetic factors. So some mothers are just by chance, by genetic chance, at higher risk for having damage from alcohol, and some fetuses are more likely to have damage based on their genes. So it's not just about the dose of alcohol, it's about all these other factors. And that's one of the main reasons that we can't say what a safe level of alcohol use is during pregnancy. Even if we could, we wouldn't know all of these other factors, and it's going to vary tremendously from woman to woman. So there is no safe level that would apply across the spectrum. People ask about the fathers drinking all the time when I give talks on FASD, and I should correct the wording here. Paternal drinking is not really a factor in a direct factor in FASD. It has to do with the alcohol exposure to the fetus. But at the same time, a father's drinking has everything to do with a mother's drinking, so that the pattern of the father's drinking, the boyfriend's drinking, the husband's drinking, has everything to do with the mom. So if you want to do prevention and if you want to think about risk, look to the father, because that's a point of risk. If he's a heavy drinker, mom is more likely to be a heavy drinker, and look to prevention. If the father can stop his drinking and get treatment, it makes it more likely that the mother will do the same. So I want to just make this point that we really have moved well beyond blaming women for fetal alcohol spectrum disorders. This is a complex societal problem. We know that the public still really misunderstands these risks, and that's partly the fault of us, healthcare professionals and researchers. We haven't conveyed the messages clearly. It's partly the fault of the media, and it's partly human nature for not necessarily believing something that is not as obvious as it might be. We know that women of childbearing age drink heavily, so this is just part of our culture. FASDs can occur from binge drinking, which is also socially acceptable. Certainly in college and even high school levels, binge drinking is a widespread phenomena. And we know that FASD occurs when a mother doesn't even know that she's pregnant. And we know that alcoholism is a very challenging condition. So all of these factors make this much more complex of a situation than just bad mom. Let's blame mom for using alcohol during pregnancy. This is a very complex societal problem. It occurs really across the spectrum, so it's not just a problem in populations who have poverty or populations who have substance abuse. It occurs in women who would think of themselves as social drinkers. The safest approach really is no alcohol use during pregnancy or even when trying to become pregnant. Here are a few more risk factors for alcohol use during pregnancy. So obviously, again, if we have a family history of alcohol abuse, we're going to have a person who's at higher risk. If a woman has had treatment, especially inpatient treatment for drug or alcohol use or mental health, that puts her at high risk for having a child with FASD. Obviously, having one child with FASD puts you at extremely high risk for having another with FASD. So the highest risk prevention programs target these women. Not using contraceptives, unplanned pregnancies. Obviously, there's a role here for birth control efforts to be part of the prevention equation for FASD. And again, alcohol use by partner and factors that affect women in such a way as to put them at higher risk for substance abuse, like physical abuse, emotional abuse, sexual abuse. So we have ways of identifying which people are at high risk for having babies with FASD. I'm going to talk briefly about the brain in FASD now. Some of the research that I do involves neuroimaging, where we're trying to learn about what happens in the brain to kids who are exposed prenatally. We use MRI, and this is really still a research tool. It's not a diagnostic tool. We're not going to put someone in a scanner and say, yep, they have fetal alcohol spectrum disorders. But this has allowed us to really learn a lot about the brain in FASD. If you've been exposed to FASD educational materials before, you might have seen this slide. And I like to show this because I think that this is obsolete. This is a normal brain here on the left, a 6-week-old baby. This is not a normal brain, and is what is presented as sometimes as the example of fetal alcohol syndrome brain. This is really not what the vast majority of brains look like. I've never seen a brain in a living child that looks like this, even in kids who have severe FAS. In fact, they look more like this, and even this is an extreme case. So here you have on the left a normally developing 12-year-old male. The brain looks healthy. Here on the right you have a 12-year-old with fetal alcohol syndrome, pretty significant FAS. And the arrows are showing you a couple of the major structural abnormalities. So this white band of fibers here in the middle of the brain is the corpus callosum. This child with FAS has some pretty significant developmental abnormalities in his corpus callosum, especially at the back. So this back part is very underdeveloped. He also has a cerebellar abnormality. This part of the brain that looks like cauliflower here is the cerebellum. And you can see all of this black space that's fluid that has filled in because his cerebellum is very underdeveloped for the rest of his brain. This is somewhat, this is an extreme case of fetal alcohol syndrome. Most brains, in fact, look relatively normal. So here's just a slide to show you that in most cases we can't tell that a brain has FAS or FASD just by looking at it. What we have done is start to try to develop some techniques and to use some techniques that look at things in a more microscopic level. So we're using this tool. This is just an example of something called diffusion tensor imaging, where we're looking at the white matter of the brain's wiring, and these colorful spaghetti figures here are graphic illustrations, graphics illustrations showing you what the wiring looks like in this child who has this corpus callosum abnormality here. You can see in the back part of this child's brain there's some pretty profound abnormalities in how the wiring is laid out through the brain. So in most cases it's more subtle than that, but we know now through a number of studies, our own and others, that the wiring of the brain is disrupted in FASD. So here's another example of that, where back in 2006, we found in a group of kids with FASD these abnormalities in the back part of the corpus callosum, very different from the normal, healthy, developing brain. We wanted to find out how this affected the brain's functioning, and so this is a little bit technical, but I think it illustrates a point. So I'll show you in a little bit of detail here. Here's the child. These are MRI data, fMRI data, from a child lying in a scanner, and we're scanning the brain for 6 minutes here. So at the bottom of these graphs, you see 6 minutes in seconds here. And these two lines, red and blue lines, are showing you what's happening in the right side of the brain and the left side of the brain in one specific region. And normally, this is a child without FASD here on the left. You can see that what's happening in the right and the left is very nicely correlated. The signals are very similar, and that's because the brain is communicating between the right and the left. If you like correlations, you can see this is about a 0.9 correlation, very tightly correlated. Here's a child on the right with FASD, and you can see that there is a lot of difficulty coordinating what's happening on the right and what's happening on the left. The signals are not lined up. They're not of the same height or depth, and they're just not as coordinated, and the correlation is quite a bit lower. So this is what we think is part of what's happening with these individuals 24 hours a day, 365 days a year. The brain is not wired correctly, and therefore it is less efficient as a result of that. Individuals with FAS, I mentioned, have all of these kind of cognitive abnormalities, but we know that there's a range. They can range all the way down into the 40s to all the way up into the very high functioning levels. And the average IQ that we see typically is about the mid-80s, so maybe about a standard deviation low. We know that these are individuals who have executive functioning impairments, and I mentioned all of these things, but here's some examples. So these are individuals who might have problems generalizing. So they might be able to learn things, but they won't generalize very easily to other situations. They might have difficulty reading nonverbals, like reading people and situations, things that are less overt, things that are more abstract. Many parents will tell us that these are kids who have difficulties understanding even the basics of time and money, and they also have a lot of trouble learning from their experience and understanding what's going to happen in the future. Working memory is impaired, so cognitive concentration, being able to hold information in mind while you're doing something with it, being able to concentrate for a period of time, is one of the most universal abnormalities that we see in FASD. Here are some other examples of executive functioning. Again, not learning from consequences, failing to respond to rewards, having difficulty sort of guiding themselves, entertaining themselves, problems understanding complex language like jokes and sarcasm, being naive and gullible. So these are oftentimes individuals who will be taken advantage of because their understanding of nonverbals and social situations is not as good as it could be. So they may be able to not identify someone who's trying to take advantage of them or a dangerous situation. We've had cases where kids will do things like confessing to a crime that they did not commit because they are so influenced by the severity of the situation involving police and things like that, that they sometimes don't understand the consequences of confessing to something. So these are some impairments that a person with working memory difficulties might have. They might be having difficulty following multiple steps. They might be oppositional. They might not know how to ask questions. They might have trouble with changes in routine. In terms of language, it's really the complex language where the impairments show up. So they might have irrational speech. They might have problems not understanding what others are saying to them. They might have frustration in communication. Even though they might have normal grammar and they might have normal vocabulary, they can have profound communication difficulties. Here's some of the behaviors that we frequently see in kids and adolescents with fetal alcohol spectrum disorders. Some of the big ones like attention-seeking behaviors, problems with personal boundaries, social difficulties, trouble understanding rules, slower than normal in terms of actually just processing speed, being disinhibited or not being able to stop themselves. Some of the strengths that we see in individuals with FASD, oftentimes these are individuals who are generally, can be likable and very friendly. They may be very outgoing and sociable. They may have not so much anxiety about strangers. Now this can be a challenge because sometimes their social boundaries are not good and they may put themselves in risky situations because they don't have those social boundaries. But they also can be very hardworking, especially if they're being asked to do something that is very clear and there isn't a lot of abstraction involved. They can be determined and resilient. Oftentimes, kids with FASD are coming from backgrounds where they've survived somewhat traumatic backgrounds, unpredictable parents, high-stress family situations, abuse, neglect. So sometimes these are very resilient individuals. Oftentimes we see that they are attention-seeking and, in fact, want to please, want to be liked, and that can be a strength. I'm going to give you just a very quick run-through of a case just to show you a little bit about what this might look like. So here's an example of a 13-year-old girl who was referred by a caseworker. She's been in residential treatment. She has long-standing attention problems and learning difficulties. She has aggression and poor judgment, unsafe behaviors. Medications have not really helped her. Her IQ, you can see, is quite low. 58 is a couple of standard deviations below normal. So this would be intellectually impaired. And as a result of that, she's impaired in almost every cognitive area that we can measure, things like memory, attention span, reading, math. She also has problems taking care of herself. She has classic FAS, so her head is small, she has small eyes, she has a flat philtrum and a thin upper lip, and she has growth deficiency. So her diagnosis is FAS. She is probably going to have lifelong impairments. Not probably, she will have lifelong impairments. She's going to have limited capacity to finish her education and to work, and she's probably going to have high levels of psychiatric difficulty. She will almost certainly need some level of assistance with daily living. That could include residential placement, certainly educational programming as well, because she has lower intellectual functioning. Maybe a case that you might not necessarily think of as FASD is this individual who's 18. He actually has some legal charges pending against him that probably relate to his judgment, but also to his willingness to confess certain things. And he's unfortunately been labeled as a sex offender because of the fact that he's had a sexual relationship with a girlfriend who happens to be underage. And this is a situation where this is an individual who's 18 but is developmentally functioning at a much, much lower level than that, much younger level. He has a long history of social difficulties, poor judgment. He has been thought of as autistic at various points in time because of his social difficulties. He has learning disabilities. He was adopted, and we know that his mother used alcohol and other drugs. But he doesn't have the classic characteristics. He has normal growth, normal facial features, head size is normal. But he has a number of cognitive impairments, although he does not have low intelligence. He has impairments in other areas. So he ends up with a diagnosis of ARND. Chances are he's going to have psychiatric issues as well. You can see he has some depression and anxiety, and he's going to need specialized legal help. He's going to need some therapy, probably psychiatric care, and probably help with daily living as well. So you can see the range here of difficulties. It's not just people who have intellectual impairment. This is a very costly condition. I won't spend really any time on this other than to say that obviously with lifelong impairments like this, you're talking about a huge, huge cost to society in terms of medical care, social help, criminal justice needs, substance abuse, and lost productivity. You may have seen some of MOFAS's, Minnesota Organization on Fetal Alcohol Syndrome's prevention campaigns, and this is really a critical part in preventing these conditions, is making this a topic that is more in the public eye. So MOFAS, these are some examples of how MOFAS has basically taken the standard public health message and made it far more appealing and attractive to the average person who's walking around and seeing these billboards and seeing these ads on buses. This is a way of making it more accessible and making people affiliate more with the message. And there are some of the public health messages that they've used are pretty dramatic and get your attention, but also give you a very clear message. Here, giving your unborn child a beer is just as ridiculous. So very clear-cut messages, but that capture your attention quickly. This is sort of the cutting edge of prevention, I think, is this kind of sophisticated messaging that really gets to a different audience. We know that women are seeing these messages, but yet we know that the public still misperceives the risks, like we talked about earlier. Unfortunately, medical practitioners are still getting the message that they're still giving the message that this is not as serious a topic as it really is. And I think that comes from a number of factors, one being just the lack of comfort in talking about these issues causes professionals to not necessarily give a clear, straight message. So we need education, obviously, but we need really changes in the social norms about drinking to make a dent in this. In conclusion, we know that FASD is 100% preventable. We know that this damage to the brain and this physical damage can happen at any point in development, not just early on. We know when the face develops, but we know that the brain is developing throughout the pregnancy, and the damage can occur at any point. The behavior, learning, physical, intellectual problems are lifelong. This doesn't go away. You don't outgrow this. These are lifelong disabilities. And FASD, we know, cannot be cured. It can only be prevented. So I'm going to stop there. I think we're right on time. We have about 15 minutes for questions, and I think Ruth has the questions.
Thank you so much, Dr. Wozniak, for your presentation on the FASD basics. In a moment, we will start with the Q&A session of the presentation. Just as a quick reminder about continuing education, again, for individuals that are seeking social work, addictions, or educator continuing education, immediately following the webinar, you will be prompted to complete an evaluation in order to receive a certificate of attendance. Again, that's for social work, addictions, and educators. For physicians and nurses, in order to receive a certificate of attendance, you will need to use the following password to access your certificate of attendance. It is capital FASD B10. I will also send that out in the chat box. Again, that's FASD B10. Please make note of that for your records, and you will need to access your certificate online. We will send out the link to access certificates for physicians and nurses following the webinar. But again, please make note of the FASD B10 password to access your certificate. So right now, I will go ahead and open up for questions. A question had come in about getting a copy of the PowerPoint. Handouts were distributed prior to the start of the webinar. If you did not receive the handout of the PowerPoint, please contact myself, Ruth Richardson, and we will ensure that you get a copy of the PowerPoint. And Right now, that looks like it's the only question that has come in at the moment. I'll give folks opportunity to enter any questions that they may have right now. And while we wait a moment for information to come in to see if we have any questions, I will just remind everyone who's on the call today that MOFAS is having its annual conference, which will take place on November 13th and 14th at the Minneapolis Marriott Northwest. This year's theme is FASD and human rights, and we've got 20 breakout sessions that are designed to appeal to professionals, educators, doctors, social services, law enforcement as well. So just wanted to give individuals a reminder of the conference that is coming up soon. So we've got a question here, Dr. Wozniak, for you. With all the research and clear information about the damaging consequences of prenatal alcohol exposure, why, in your opinion, are some doctors advising patients that small amounts of alcohol are okay?
Okay, so this is, I think, a pretty complicated issue, but a really important one. Maybe I'll step back and kind of describe a little bit of the research. And there's sort of many different levels of research that goes on around FASD. The biological research, the laboratory research involving things like animal research or cell cultures is very clear that alcohol does this damage even at low levels. Okay, so that line of research is very straightforward, but people are always hesitant to extrapolate from animal studies, even though for the most part we know that these same principles apply to humans. But the general public oftentimes pays more attention to studies that involve humans. It's very difficult to determine anything about dose of alcohol or amount of alcohol in humans because you cannot do an experiment, right? You can't assign people to drink or not drink during pregnancy. You can't give them different levels of drinking and then study the effects. And there are very big problems with looking at the way there's the natural variation in people's drinking, because people who drink heavily also have other characteristics, like they smoke heavily and they are more likely to be lower education and they're more likely to have poverty situations. So it's very difficult to study in humans. The studies that have actually been done that talk most about low levels of drinking come from Europe, and these are epidemiologic studies. So they look at a couple thousand births, and they ask women about their alcohol use during pregnancy, and then they study the children a few years later. And those studies are the controversial studies that showed in low-level to moderate-level drinking that they were unable to detect any problems in those children. The difficulty with those studies is that they used a few measures, and they measured the kids when they were quite young. So they may have looked at something like balance, which is a very gross measure of developmental outcome. And it's not a sophisticated measure like a computerized measure of attention, for example. And so the fact that they didn't find effects probably means that they missed the more subtle effects in those populations who have low to moderate alcohol exposure, or at least that's a possibility. So physicians and other professionals look at that research, and that's one of the factors I think in why they sometimes give the message that some alcohol use during pregnancy might be safe. I think they also don't know about the genetic factors that I just talked about. They don't know about the nutritional aspects. They don't know about the random characteristics that make some women at much higher risk than others. So part of it is just lack of understanding of the research. And I think the biggest part of it, though, is the comfort factor, that we have a certain level of comfort with drinking in our culture, even excessive drinking, we as a culture, we're comfortable with that. And certainly we're very comfortable with social drinking. And we think it's a normal thing. And it is a normal thing. But as a result of that, the physicians are not willing to take a hard line. They don't want to appear moralistic. They don't want to appear judgmental. They don't want to lose the relationship that they have with their patient by seeming too rigid on this issue that everyone basically does, other than when they're pregnant, right? So I think it's a combination of those factors that leads to this, number one, lack of discussion between medical professionals and patients, and number two, lack of a clear message even when they have a discussion.
Thanks for that response, Dr. Wozniak. Again, it sounds like a very complicated social issue, and it's not just one thing, as you were explaining. It's lots of factors coming together that continue to lead to that messaging. The next question is related to the DSM-5. Why is FASD or FAS not a diagnosis in the DSM-5?
Okay, this is a good question. The DSM-5 is this manual of psychiatric conditions and developmental conditions that psychiatrists and psychologists use. And this just came out, the fifth edition just came out this past year. And the process is extraordinarily long, and it is essentially a committee process. So what's in the DSM-5 is in there because various committees have met over periods of years and decided what's going to be in there, what's not going to be in there, what are the criteria going to be. It is literally that. Committees decide these things. So there was consideration of FASD, and I think largely the reason why it didn't make it into the DSM has to do with the fact that there's disagreement still about the criteria. And that's even among the experts, expert researchers and expert clinicians, there's still disagreement about how can you best make this diagnosis in a way that's accurate, reliable, and sensitive and specific. So that's where the problem lies. What we were left with in DSM-5 now is pretty vague, and it's neurobehavioral disorder with the acknowledgement that there has been prenatal alcohol exposure, and that's sort of a vague set of criteria. I mean, it's not criteria at all. Basically, it is just a statement of fact that the person has a developmental disability and they were exposed to alcohol. In the DSM-5 appendix, there are criteria that are under consideration for the future, and so these are sort of considered research criteria. And those, although they can't be used to make a diagnosis, can certainly be the guideline for the kind of the next step of the process in actually creating real criteria.
Great, thanks for that information. I know that there has been a lot of questions about the new DSM-5, and I think that will continue, and it's something that I know that you and MOFAS definitely will be tracking on in the future as well. The next question is actually for me, and it's related to explaining the process for obtaining certificates of attendance again. So I'll just do a quick run through of that. Again, social workers, addictions professionals, and educators, immediately following this webinar, you'll be prompted to complete an evaluation. Once you complete that evaluation, within 7 business days, you will receive a certificate of attendance via email. So be sure to complete that evaluation if you are a social worker, addictions professional, or an educator. Again, for physicians and nurses, please make sure that you take note of the password FASD B10. It's currently showing in the chat box. And following the webinar, you will receive a link to enter that password in order to access your certificate of attendance. If you have any other questions about certificates of attendance, you can feel free to reach out to MOFAS following the webinar. So next question for you. Dr. Wozniak. This is coming from a social worker, and the question is, as a social worker, what are 3 things that the person can do to assist a child with an FASD, one that's in legal trouble and part of the Human Services Department?
Okay. So I'm not 100% sure I understand the question, but it sounds like the question is generally, what can a social worker do to assist a client who has an FASD, who's involved in
The
a
legal
legal situation?
system, and it sounds like maybe child protection.
Yeah. Well, I think one first step is that if the child, excuse me, has not already had a comprehensive assessment for fetal alcohol spectrum disorders, he or she should have that done. And this is a process that takes place in specialty clinics. We have one at the University of Minnesota. MOFAS has a specialty clinic for diagnosis, and there are a couple of others around the state. There is information on MOFAS's website about these clinics. If the child has had one of those assessments and has not had a recent reassessment, that may also be indicated. So knowing some things about the child's, basically their symptoms, their cognitive development, their capacity to understand the legal process is really important, and that can all take place within that assessment. I think there are some particular things that probably need to happen in terms of guiding an individual with an FASD through the legal system. And I know that there are some resources available through MOFAS, which maybe Ruth can talk about in a second here. But in general, these are individuals who, again, are going to need extra assistance to navigate some of these systems, even down to the level of having someone present with them to guide them through things like interviews and meetings with attorneys and things like that, so that to make sure that they understand the process and to make sure that the explanations are tailored to their level of understanding. Ruth, do you have any practical information you can give about the legal aspects in terms of what MOFAS can offer?
Sure. I think a couple of things, especially in the context of social workers, I would wholeheartedly agree with you about the first step in terms of ensuring that there's been a comprehensive FASD diagnostic assessment conducted, and some clinics are able to expedite those appointments, especially when it's linked to a pending court case. So I would encourage social workers that if you are involved with an adolescent in the juvenile justice system and there's a need for a comprehensive diagnostic assessment, that when you're reaching out to the various clinics, again, the U of M has a clinic. We also have one here at MOFAS as well, that you indicate that that it's a child protection issue or it's a juvenile justice issue, so that we're able to expedite those for you accordingly. One of the other things that I would suggest as well that's practical is whoever is representing that child, having them have the knowledge of resources that are available to help in that defense. MOFAS is available as a resource. We do have a justice initiative that we are working on, and we're able to provide individuals with resources such as the recent American Bar Association resolution that's urging all attorneys and judges to be trained on FASD. And as a result of that resolution, MOFAS has been training judges and attorneys across the state since 2012. So I think a big part of it is just ensuring that the individuals that are involved in that case, including the attorneys, are aware of what resources are out there in terms of answering questions, and again, getting to an understanding of what FASD can look like or how it may present, especially as it relates to, as you were saying, Jeff, competency issues and capacity issues. So that would be, I think, an important second step, is to try to share more about the resources that are available. Okay. So it looks like we have answered all the questions that have been presented, and we are right on schedule. So I'd like to, at this time, thank Dr. Wozniak for his presentation, and also like to thank all of the attendees for joining today's presentation on the FASD basics. I hope everyone has a wonderful afternoon. Thank you.
Thank you all.